I would like to invite the first speaker, Dr. Sumeet Lahane is there. So he's going to speak on evaluation of the Lacrimal system.
Good morning, everyone. Welcome all of you to this Aishala in the DreamCon. I thank Dr. Santosh Onava sir and the AIOS Scientific Committee, Organizing Committee for giving us opportunity to be here. So what I will be discussing is the evaluation of the lacrimal apparatus. So this is how the 30 to 40% of the patients come in your OPD complaining of आँख से पानी आ रहा है, it's watering. And how do you approach this epiphora cases? So epiphora is nothing but it's implying that there is a overflowing of the tears, and when there is a overflowing, either there is a hypersecretions or there is a drainage that is blocked. So this is something that is not given anywhere. It's a grading of epiphora. It's basically no epiphora is grade 0. Grade 1 is when you go into a windy storm kind of a weather, then there is epiphora. Otherwise, grade 2 is outside epiphora without irrespective of the weather, and the third is there is outdoor, indoor, irrespective of everything, there is epiphora. So now when you want to enumerate the causes, theoretically there are a lot of causes, hypersecretions and the defective drainage. So hypersecretion has a lot of causes from neurogenic, abnormal lid globe position, ocular surface disorders, facial palsy, and lot of it to remember and write. Now defective drainage, again there is everything blocked from the punctum to the nasal conditions, and again there are a lot of causes, boring, difficult to remember. So when you have so many causes and you don't know how to go ahead with, theoretically you may be able to just read again and again and write it, but it would be best when in your OPD you know how to approach a patient. So when the steps are difficult, the stepwise approach is always better. So, taking into consideration the all of you know the anatomy of the lacrimal apparatus, two things that we keep on forgetting in this is wall of Hassner and the wall of Rosenmuller. So, you try to remember any which way that the upper is R and lower is H, RH, any which way, whatever fits in your brain, try to remember this way. So, Rosenmuller, for your information, was basically a anatomy professor from Germany who discovered wall of Rosenmuller almost 200 years back, and wall of Hassner was ophthalmologist. So in the step 1 of your practical approach, the first most important thing that you should do is do a clinical examination. Try to see on the slit lamp, because many of the times, especially in the elderly and very younger population, what you miss is a punctal occlusion stenosis or the absence of the punctum. And this is a very much easily treatable condition. If there is a punctal absence, then of course you need a tube. But if there is a occlusion or the stenosis, that can be very well treated. So this is a small simple surgery which everyone should learn even during their residency. So you dilate the punctum, you make two snips, one lateral and one medial, and you just join, and that's it. This is your punctoplasty. I will just repeat the video for you again. So you dilate the punctum, you do put a topical anesthetic, do give a 0.5 ml of lignocaine, two snips and three snips joining them. So it's very simple and easily doable procedure which solves your issue. Now step 2, when there could be some other cause other than punctal stenosis, when slit lamp examination is normal. So there could be block anywhere. It could be upper lower canaliculus, common canaliculus, or NLD. Then what test comes to our help is a sac syringing test. This is one of the first tests maybe in the OPD after retinoscopy that all of us as a PGs do. But the interpretation we never learn. So how do you interpret this? So very first important that we should try and follow the protocols when you are doing this sac syringing. Ideally we should use a glass syringe. Most of us don't have in our medical colleges, but the glass syringe will be ideal with the good nice cannula which is made specifically for the probing, for the syringing, sorry. So this is a patent syringing. When you put it and the patient sees that I can get the water in the throat and that's it, your canalicular lacrimal apparatus is clear. Now, when you get a regurgitation from the same punctum, what do? Either it comes from the lower or upper. In this example, I'm showing you the lower canalicular block and you get the reflex from the same punctum. You also have a difficulty in passing your cannula. So then you repeat the test from the other canaliculus and see is it patent or not. So if it is patent, then you know the other canaliculus is blocked and partially it is the other one is open. So you know this is a canalicular block either upper or lower. Then, when you're doing a sac syringing, there is a regurgitation. Now, you need to be little more experienced to understand that regurg is coming very fast or it is taking some time. It will be from both the puncta as such. So, if it is very fast, then you know it's common canalicular obstruction. It is taking some time, then you know. But again, in the early phases, it is difficult to understand, and when we do it forcefully, again, we cannot interpret that how fast is the reflex coming. So, what do you do in such cases? Then there is a step 3. Then you are not able to differentiate between a common canalicular and the NLD block. Then you do something called as a probing. Okay. Then this is a Bowman's probe. There are various sizes available. So you dilate the punctum and pass the probe. So when you feel a soft stop anywhere between the canaliculus, 7 to 8 millimeter, that's what the length of the canaliculus is, and then you know it's a soft stop and there could be a common canalicular block. In common canalicular block, again you will notice that the medial canthus of the patient is getting shifted towards the medial side when you're doing it very forcefully and patient is experiencing pain. So you know this is a soft stop, and now what are you dealing with is basically the regurg is coming from the early block, which is a common canaliculus. Hard stop is something that you're able to pass the probe very easily, but you're hitting the bone and you're not able to pass it further. And that time you know the canaliculus is basically clear, and what are you dealing with the nasolacrimal duct. So step 1, step 2, step 3, all simple. You do it in a phased manner and you understand. Now what happens, the problem, here the treatment is either canalicular DCR or DCR depending on the block. The problem happens when there is a partial block with the clear regurg. When patient is complaining that there is issue and you get a hard stop, and then there are 2 residents doing it. One very thin, lean, and he says that yeah, there is a regurgitation happening. Another fat fellow comes and uses all his force and all the anger on the professor is taken out while doing the sac syringing, and suddenly he finds it is patent. Now there are 2 different findings in the same patient, and there is a fight that it's patent or it is regurgitation. So now when you are stuck at this phase, now the help comes with the step 4. So this is the dye test that we do. There is a drop of a fluorescein that we put in your conjunctival cul-de-sac, and you put a bud which is dipped in a lignocaine or proparacaine, and then you keep it in the nose. Then if you get it all stained, then that's a positive thing. And the positive Jones 1 test is basically the system is patent and the watering is because there is a hypersecretions. Now if you get negative test that your bud is not getting stained, and this is a more of a physiological step, you are not using any extra force to put the stain ahead like you are doing in the sac syringing, then you know that the blockage is either upper lacrimal system or the lower lacrimal system. So either there is a pump failure or there is a partial obstruction. Now, once the test comes negative, we need to do another test. So that's called as a Jones dye test 2. In this, we purposely do a sac syringing and try to force the whatever fluid or the whatever fluorescent dye which is already there in the lacrimal sac or in the conjunctiva. So suppose it has already entered the lacrimal sac because the pump is working well, and you put it very forcibly and then you get it, then you know that the upper lacrimal system functional and partial block is in the lower NLD. And the second time negative test basically tells you the upper drainage system is faulty. That is a pump failure. Basically your orbicularis and the lacrimal sac are not functioning well and there is a problem. So this is a Jones dye test 2 negative, and you have a pump failure upper side. So in pump failure, again doing any surgery is futile and that may not work in the patient, but instead you get a positive test in the second attempt, you know the DCR will be a good treatment for this. So again, just to revise, step 1 is clinical examination because you want to see that is there any problem with the punctum itself or any other small things which you will come to. Step 2 is you do a sac syringing and try and interpret. You will get stuck only when there is either a common canaliculus block or there is a NLDO block. Then you do a step 3 which is probing. So you either get a soft stop and hard stop, then you are able to differentiate. And fourth, you have to do only when there is a problem that there is a partial regurgitation and partial patent and you don't know what is the problem happening and should you operate or you should not. This test will help you to do that. There's one more test, dye disappearance. This is more useful in the children, when you know they are not let you examine, you can just put a fluorescent drop, and they're crying in your OPD, you can tell them to come back after 5 minutes, not to wipe eyes, tell their mothers. And then you see after 3 to 5 minutes also the dye is still there, then you know that there is some problem with the lacrimal system. So this is a dye disappearance. So many times parents are not able to tell you that which eye is watering. There are few causes which all of us should not forget, especially in children. One is epiblapharon. These are again some causes of the hypersecretions and not of the lacrimal apparatus problem. Another is trichiasis. Another is congenital glaucoma. And this is something that you again miss. That patient is completely normal. The punctum is still open, and you are doing sac syringing. It is patent, but patient has a positive dye disappearances and not able to you're not able to find a problem. This you will find in a young adolescent person. So here some findings I would like to show you. You see this hair between two eyebrows. Anyone, what is it called as? Raise your hand. Yeah, synphresis. So basically this one feature. Another one, I have put an arrow where you see that the angle, here you see the angle of the medial canthus, and especially it's very much acute angle. Thirdly, when you see on the slit lamp, you will find the eyelashes which are there. The pars ciliaris, basically it gets over at the punctum, but in this case you will see that those eyelashes are covering the puncta as well. So all these features basically constitute nothing but a Centurion syndrome, where you find everything normal, but again there is a patient having watering. That is because of the configuration of the all lacrimal apparatus, and this is again a very easily treatable situation. Only thing is you need to diagnose it correctly and not keep on giving patient eye drops which will increase his watering instead of relieving him. So these are the conditions which you should not miss on your clinical examinations. To summarize, epiphora should be differentiated from the lacrimation. Stepwise approach is must, and well done syringing and probing, and more than that, well interpretation of the same is very important. And DCR and intubations are important surgical procedure which you must learn in your residency itself. I thank you all for patient listening.